Hi, welcome to the SHARE webinar, Less Pain, More Gain, Palliative Care Strategies for Recurrent Ovarian Cancer. This is SHARE's third annual Joan Summer Educational Program. We're going to wait just a minute or two more for folks to sign on. So, yes, we'll just wait a little bit. All right, we'll get started. So this is Less Pain, More Gain, Palliative Care Strategies for Recurrent Ovarian Cancer, SHARE's third annual Joan Summer Educational Program. I'm Stephanie Blaufar, Program Manager at SHARE. Before the presentation begins, I'd like to tell you a bit about SHARE and about Joan Summer. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 40 years by offering the support of those who've been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. All of our services are free of charge to participants. For more information, visit our website, sharecancersupport.org. For those of us lucky enough to have known Joan, this annual program is a lasting testament to her ability to inspire us. Joan, a nurse, lived 21 years of her life after a diagnosis of stage 4 ovarian cancer. She and her husband, Joe, showed us how to engage with a medical team and make informed treatment decisions while living life fully and raising their 3 children. Joan was generous with her time, her wisdom, and her humor. She volunteered for SHARE and the Ovarian Cancer Research Fund, and we miss her. Her husband, Joe, continues to support SHARE's ovarian program to help other women and families cope with ovarian cancer. During this presentation, all participants will be muted. When the presenter finishes speaking, we will open up for question and answer discussion. You're welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember, the presenter is unable to give specific medical advice, so please keep your questions general in nature. Also, this presentation will include some audience participation polls, so keep an eye out for those. This webinar is being recorded and will be available on the SHARE website soon. And now I'd like to introduce our speaker. Dr. Carolyn Lefkowits is an assistant professor of obstetrics and gynecology and internal medicine at the University of Colorado, Denver, where she practices both gynecologic oncology and palliative care. Dr. Lefkowits is passionate about integrating palliative care into the care of women with ovarian cancer in order to provide an extra layer of support and optimize quality of life throughout the disease course. She trained at Harvard for medical school and her Master's of Public Health, at the University of California, San Francisco for OBGYN residency, and at McGee Women's Hospital at the University of Pittsburgh Medical Center for fellowships in both palliative care and gynecologic oncology, and a Master's of Science in Medical Education. Wow. All right, so now I hand it off to you, Dr. Lefkowits.
Awesome. So I am just delighted to join you all today to talk about a topic that's really close to my heart, and we'll be talking today about palliative care integration in ovarian cancer. As Stephanie said, I practice GYN oncology and palliative care here at the University of Colorado. I do primarily GYN oncology clinically, and then a half day a week I see patients in palliative care clinic with any kind of cancer. And so I'm delighted to be talking to you about both of those disciplines today. So my objectives are that by the end of our time together here, you would be able to define palliative care and differentiate palliative care from hospice care, list at least 3 evidence-based benefits of palliative care, and we'll talk about some of the studies of those benefits, differentiate between primary palliative care, which is delivered by the oncology team or your primary care provider, versus specialty palliative care delivered by a dedicated palliative care team. And then I'd like you to leave tonight with homework, and that homework will be to familiarize yourself with the palliative care resources available to you wherever you are. So in terms of an outline, we'll start by talking about what palliative care is and isn't. And then I'm going to review some of the evidence supporting the benefits of integrating palliative care into the care of women with ovarian cancer, or why do we need palliative care. Palliative care can be delivered in lots of different ways, so we'll talk about some of the ways that you can get it. We'll go over some barriers to optimizing the integration of palliative care into the care of women with ovarian cancer. And then we'll talk about next steps toward improving integration of palliative care into the care of women with ovarian cancer. So here comes our first audience question. Stephanie, you want to run this?
Okay, I will run this, yeah. So let me launch the poll. Okay. So how knowledgeable are you, if at all, about palliative care? So audience members can click on the options here and can submit, and the options are you very knowledgeable, knowledgeable, somewhat knowledgeable, not at all knowledgeable, or you're not sure. So we'll wait just a couple more seconds to see if we can get others to participate in the poll. All right, it looks like we have a good percentage. So I will close this poll and share the results. Okay, so we have, for how knowledgeable are you about palliative care, we have a third of the people said that they are knowledgeable, and 2/3 said they are somewhat knowledgeable.
Awesome.
Back to you.
And so this question is taken from a national poll that was done by an organization called the Center to Advance Palliative Care that we'll talk about later. That was a poll of the general public asking sort of what people know about palliative care. And to give you a preview, I would say it sounds like our audience here is more knowledgeable than the general public, even going into this discussion, so that's great. So what is palliative care? You may read lots of different definitions out there. The definition on this slide here is from the American Society of Clinical Oncology, or ASCO. And per ASCO, palliative care includes therapies that address the multiple issues that cause suffering for patients and their families and impact their quality of life. And just to dispel upfront a common misconception, palliative care is not synonymous with end-of-life care. It can be offered at any point in the disease course for a serious illness such as ovarian cancer, concurrently with therapies like surgery, chemotherapy, or radiation, including when the goal of those therapies is cure. And this is another definition that I like a lot. This is from this organization called the Center to Advance Palliative Care that I mentioned, and I'm going to just go ahead and read it to you. Palliative care is specialized medical care for people living with serious illness. It focuses on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. It is appropriate at any stage in a serious illness and can be provided along with curative treatment. And this definition goes on, it's actually quite long, but to include the phrase that is kind of my favorite phrase from the whole paragraph, which is palliative care as an extra layer of support. And this phrase, an extra layer of support, comes from this public opinion survey done by the Center to Advance Palliative Care. I'll tell you more about it later. But essentially that found that a lot of the public doesn't know what palliative care is, and they were looking at different ways to kind of summarize it. And this phrase, an extra layer of support, really resonated with people, and it's one that I use all the time, both with patients and with my colleagues, other physicians, to try to really encapsulate what palliative care can bring to the care of women with ovarian cancer and other cancers. And so our first objective was that you'd be able to define palliative care, and I think the easiest brief definition is that palliative care offers an extra layer of support. So when we talk about palliative care, I think it's important to spend most of our time talking about what it is as opposed to what it is not. But I do want to make sure to drive home the point that palliative care is not synonymous with hospice care. Hospice care falls under the broader umbrella of palliative care. But hospice, unlike palliative care, is only available to patients with a limited prognosis, generally has to be an estimated survival of less than 6 months, who are no longer planning any cancer therapies like chemo, surgery, radiation. Palliative care more broadly is not limited in either of those ways, so is not tied to prognosis and does not at all impact access to, so accessing palliative care or incorporating palliative care in the setting of an ovarian cancer diagnosis doesn't limit access to other cancer-directed therapies, surgery, radiation, chemo. So in summary, kind of all hospice care is palliative care, but hospice care represents only a very small subset of palliative care overall. And this is just sort of trying to represent that same idea in sort of a pictorial representation of the idea that palliative care can be offered alongside cancer therapies, including curative intent therapies. And so this just kind of illustrates that palliative care can be offered from the time of diagnosis alongside curative intent care. And I don't think that it quite goes in a straight line like you see here in this graph. I think it's more that the amount of palliative care that a woman and her family may need can kind of go up and down over time, depending on where she's at in her treatment, what her symptom burden looks like, what decisions she has in front of her. But the point being that it can be offered alongside curative care with advanced care planning throughout the disease course. And then for patients who do ultimately pass away of their disease, hospice care near the end of life and bereavement care for a family following a patient's death are part of this real broad spectrum of palliative care. And those elements, hospice care and bereavement care, also fall under that bigger umbrella of palliative care. So just to try to get a bit more concrete about what clinical services palliative care can offer, this slide has the 9 domains of palliative care as outlined by the American Society of Clinical Oncology, ASCO, and the American Association of Hospice and Palliative Medicine, AAHPM. So palliative care services can include symptom assessment and management, psychosocial assessment and management, spiritual and cultural assessment and management, communication and shared decision-making, and so that can include discussions about things like prognosis or advanced care planning. It can also include just decision-making at branch points in care where sometimes we're facing a couple of different options and trying to figure out how to best match an individual patient's goals and values to the treatment options available to her. Palliative care also can include advanced care planning, and a detailed discussion of that and its benefits and barriers is kind of beyond what we have time for today, but I think it is a critically important piece of the course of anyone with a serious illness. It's important that the loved ones and medical team of a woman with ovarian cancer, for example, has a sense of what that woman would want for herself if she were to suddenly get sick or suddenly be unable to speak for herself. And the time to talk about those things is actually when the patient is feeling well and can participate in those discussions and not be waiting for a crisis and suddenly everybody's wondering at what someone's wishes would have been. Number 6 is coordination and continuity of care, and so this can be helping to coordinate a clear message for a patient and family who maybe have multiple different doctors or specialists involved in her care. It can include helping to navigate the healthcare system. So for example, helping to match services available in the community to a certain individual patient's needs. Number 7 is appropriate referrals to specialty palliative care and hospice care. So here a palliative care referral is referencing specialty palliative care, and we'll talk more about this later, but not all palliative care needs to come from palliative care specialists. You can advocate to get good palliative care from your oncology team or from your primary care physician and your oncology team. Number 8 is carer support or caregiver support, and I think this is a growing area of research in the palliative care community. We're just starting to realize, the impact that a cancer diagnosis, for example, has on a woman's family and friends and caregivers, and that it's important to include those folks in sort of the circle of care. And then number 9 is end-of-life care, which, as we've talked about, is a piece of palliative care broadly. So let's see here. Before we go on to why we need palliative care, just to review, palliative care services can offer an extra layer of support to patients and families facing serious illness like ovarian cancer and can be offered alongside curative intent therapy with the goal of improving quality of life. And this distinguishes palliative care from hospice care, which is available only to patients with a limited prognosis who are not going to be getting further chemo or other cancer therapies. So why do we need palliative care? In summary, we need palliative care because we have high quality research and evidence that shows that there are multiple benefits clinically to individual patients and families as well as to the healthcare system. And so palliative care is an avenue to really increasing the overall value of cancer care. So I want to talk about some of the studies behind that assertion. And I had a couple of videos that I had wanted to show you guys, but from an AV standpoint, we couldn't quite work those out. So links to those videos will be available in the online version of these slides later on. So let's talk about the benefits of palliative care. At this point, there have been multiple retrospective studies showing benefits of palliative care with respect to quality of life, improved health-related quality of life, reduced pain and distress, improved patient and family satisfaction with care overall. For patients who do ultimately die of their illness, patients who have had involvement with palliative care are more likely to die at home or in the place that they have said they would prefer to die and less likely to die in the hospital. And palliative care is also associated with reduction in length of stay in the hospital and length of stay in the ICU. And importantly, all of those benefits are without any negative impact on overall survival. So it's not that people are staying shorter times in the ICU or in the hospital because they're dying faster. This is certainly a hot topic and one that comes up a lot when we have conversations about palliative care is, are we shortening people's lives? Are we giving up by including palliative care as part of their cancer care? And no study of palliative care has ever shown decreased survival. And we'll talk a little bit about how some studies of palliative care actually look like people may survive longer when we attend to these important elements of their care, like their symptom management and making sure we're matching our care plan to that individual patient's values. And I mention all this because I think it's a common fear both among patients and among providers. What if the palliative care team comes in and just tries to talk everybody into hospice? But that's not how it works, and that the data bears out the fact that palliative care does not shorten people's survival. And so I'm just going to show you kind of the most famous randomized trial of palliative care integration, which appeared in the New England Journal now, probably almost 5 years ago. And this is a study of lung cancer patients, but I think that the findings are relevant and generalizable to other types of cancer. So this was a randomized trial of 150 patients with stage 4 lung cancer, and they got randomized. So half of them got standard oncology care, meaning the oncologist could refer these patients to their palliative care team if they wanted to. And the second group got routine palliative care from the time of diagnosis, meaning within a month of diagnosis, they saw the palliative care team in the clinic, and then they saw that team about once a month throughout their illness. So importantly, this was not a trial of palliative care versus no palliative care. This was a trial of routine palliative care as part of cancer care from the start versus standard oncology care. And they found that the group that had the palliative care from the get-go, from the time of diagnosis and routinely during their course, had better quality of life, which was their pre-specified primary outcome. They had less depression. They had less aggressive care at the end of life for patients who did die during the study. And the study wasn't designed or powered primarily to look at survival, but not only did the routine palliative care group not have their survival shortened, in fact, those patients who had routine palliative care lived statistically significantly longer than the ones who didn't. And so to me, this is sort of a really strong argument for dispelling some of these myths around palliative care and shortened survival, and really nicely illustrates the benefits of having palliative care as just sort of another part of caring for patients with cancer. So that trial is probably the most well-known among now several randomized trials to have shown a benefit of early palliative care integration. And taking all those studies together, in 2012, the ASCO issued this provisional clinical opinion that they updated recently and essentially comes to the same conclusion. And they concluded that based on the total evidence available, that combined standard oncology care and palliative care should be considered early in the course of illness for any patient with metastatic cancer and or high symptom burden. So this would apply to, I would say, many, if not most, patients with ovarian cancer. And now I just want to quickly run through a couple of studies specifically in gynecologic cancer that support some of these same benefits for palliative care integration. This is a nice study that was done in Brazil, published in 2014, and they looked at a group of breast and GYN cancer patients. About half of them had GYN cancer. And this whole cohort they captured them at the time that they were essentially stopping chemotherapy and transitioning to purely comfort focus or a hospice type therapy. And then they looked at comparing the patients who had already had palliative care involved in their care prior to reaching this point when they were stopping chemo, and compared those folks to patients who had not had palliative care involved in their care prior to that point. And they called the kind of early palliative care group the integrated care model. They found that patients who had had earlier palliative care integration had better quality of life. They had less depression, so very similar to the findings in the lung cancer trial. They had less chemotherapy within the last 6 weeks of life, and we know that chemotherapy in that setting is very unlikely to extend someone's life and really can run the risk of shortening people's lives if you take someone who's sick or already close to the end of their life and give them strong medications like chemotherapy. And overall, they had improved median survival, meaning the early palliative care involved group lived longer from that point forward. This is a study that we did at McGee where we looked essentially at a case series of almost 100 inpatients with a gynecologic cancer who had specialty palliative care consultation primarily for symptom management while they were in the hospital. And we wanted to look at the impact of palliative care on symptom management in the hospital. We didn't have a control group because this was retrospective, so we essentially looked at the time course of their symptom improvement relative to the time when palliative care first saw them. And the primary outcome was the prevalence of moderate to severe symptom intensity in these patients. So we found that moderate to severe symptom intensity prevalence improved between the time of palliative care consult and discharge for pain, anorexia, fatigue, and nausea, with a magnitude of improvement on the order of about 60%. And we found that within 1 day of seeing the palliative care team, we had improvement in moderate to severe intensity of symptoms for pain, fatigue, and nausea with a magnitude of improvement on the order of about 50%. So without a control group, we couldn't prove that the palliative care consult had caused the symptom improvement, but the fact that the majority of the symptom improvement that occurred over the whole hospitalization happened within that first 24 hours of the palliative care team getting involved certainly suggests an association. And this is more of a system-level study, but Lowry and colleagues in 2013 looked at the cost-effectiveness of early palliative care integration for women with platinum-resistant ovarian cancer. And I'm sure this audience is probably familiar with that term, but platinum-resistant ovary cancer is when ovary cancer finds its way back within 6 months of finishing a course of chemotherapy that includes platinum, so cisplatin or carboplatin. This study used the benefit data from the lung cancer trial to build their model, and they modeled what would happen if every patient with platinum-resistant ovarian cancer had palliative care involved in their care at least once a month from the time that they were diagnosed as having platinum-resistant disease. And they found that doing that, integrating palliative care from the time of diagnosis of platinum-resistant disease, was associated with a cost savings over routine care, even if we only looked at the quality of life benefit. So even accepting the depression benefit, all the other benefits that we talked about, even just looking at the quality of life improvement, that remained cost effective at the systems level. And I think certainly the clinical benefits to individuals are more important than the cost savings. But I think the point is that palliative care integration is kind of the holy grail of value of care, because you have both improved clinical outcomes and improved cost effectiveness. So in light of some of those studies and others, in 2013, the Society of Gynecologic Oncology, our national society, included palliative care in their list, Choosing Wisely list, which is a list that was put out independently by a number of different specialties that included 5 things that they wanted to highlight that were either being overused or underused. And they chose palliative care as one of those things. And they advised not to delay basic level palliative care for women with advanced or relapsed gynecologic cancer, and when appropriate, refer to specialty level palliative medicine. So this highlights a couple of points, I think. First being, palliative care is an integral part of the care of women with gynecologic cancers. And second, not all palliative care is provided by palliative care specialists, which brings us to this question of how can you get palliative care? And before we go there, just to review again, the reason that we need palliative care, why do we need it? We need it because it improves the quality of care. It improves quality of life, symptom burden, at At worst, it does not shorten survival, and at best, it may even improve survival. So before we go into how can you get it, one more audience question. Stephanie, can you put us in poll mode?
Yeah, okay, hold on, let me just get this poll. Okay. So the question is, have you or someone you know received palliative care? And you can select yes or no, or I'm not sure. So now we're going to give a little bit of time for folks that are attending to answer. So we'll just leave this up for a few more seconds so that folks can put in an answer if they'd like. Okay, I think we have everybody. So it was 50-50. Half of the group says they, either themselves or somebody they know, has received palliative care, and half say that they have not.
Okay,
so
neat. Half and half. Okay, oh, and then, sorry, one more. So we put us back in a poll mode here.
Wait, do you want to see the results or a new poll?
Oh, this is the next one that's saying if you have received palliative care, where did you receive it?
Okay. Okay, so the poll question is launched. If you have received palliative care, where did you receive it? So there was a couple people who said they or somebody that they know had received palliative care, and if you want to answer, you can answer. The options are: did you received it in the hospital, you received it in an outpatient clinic, you received it at home, or other. Okay, so we have a few people that have answered. All right, anybody else want to answer? Leave it for a couple more seconds. Okay, I will close it. So these answers are divided into 3 answers. So you have a third of the folks said they had received it in hospital, another third say they received it in outpatient clinic, and another third say other.
Okay, sorry, the numbers on this version of the slide are all number 1, but clearly people figured it out.
Yes,
okay,
right.
Great. So, so a range of settings which reflects, I think, the range of settings in which palliative care is available. So let's talk a little bit about how you can get palliative care. So I think the first distinction is you can get palliative care from your oncology team or your primary care physician, and that's called primary palliative care, which refers to that sort of group of domains of clinical care, symptom management, spiritual care, critical conversations, all of those things delivered by providers who are not palliative care specialists. So your primary care provider, your oncology team, and that doesn't need to be a physician. It can be a nurse, nurse practitioner, physician assistant, social worker. And that's distinguished from specialty palliative care, which involves referral usually to a group that's often an interdisciplinary team with physicians, nurses, chaplains, social workers, sometimes pet therapy, art therapy, music therapy, but a dedicated specialty palliative care team. And the question of is such a team available, and if so, in what healthcare setting, depends on where you are. The most common place is in the hospital, to have a consult service where when a patient's in the hospital, whoever's taking care of them, the oncology team, primary care provider, can ask the palliative care team to come and see the patient. Some institutions have outpatient palliative care clinics, so that's where I see patients for palliative care visits. They come in and see me for a palliative care visit the same way they would come see their oncologist for an oncology visit, their cardiologist for a cardiology visit. And then palliative care can be delivered at home, either in the form of home palliative care, which is essentially home care services usually offered by a home care agency that focus on symptom management and the other elements of palliative care, or hospice care, the majority of which is delivered at home, again represents a subset of palliative care. So we've talked in generalities about palliative care definitions and palliative care domains, but I think it's important to try to get concrete about what happens if you, as a woman with ovarian cancer, go and see a palliative care provider, let's say a specialty palliative care doctor, either in the clinic or in the form of a consult in the hospital. What are you going to talk about? And this data comes from the lung cancer study that we talked about. And I would say, in general, the answer is you're going to spend your time in whatever way is most useful to you as an individual. The whole idea is within those 9 different domains of palliative care, the way that, say, I would spend my time in a consult with a new patient in the office is to broadly go over the scope of what we can do and then try to spend our time in the way that is most individualized to that patient and his or her family. But in the lung cancer study, so looking at the 67 patients who got their routine palliative care, their first palliative care visit in the office was almost an hour. And so right there, you can see one of the big differences, I think, about the luxury that we have in palliative care clinic generally of having an hour, or I get an hour and a half when I see a new palliative care patient. And that's just something that's not available to oncologists in the way that oncology clinics are scheduled. And in terms of the way that time was spent, the highest proportion of the time was generally spent on symptom management, so about 20 minutes. Next on patient and family coping, an average of about 15 minutes. And then finally on illness understanding and education. And I think that in general, these are things, symptom management, patient and family coping, illness understanding, that all patients with ovarian cancer really could benefit from an hour of time dedicated to those really important topics. So the Center to Advance Palliative Care, which I've mentioned a couple of times, is a wonderful national organization devoted to palliative care, and their website is getpalliativecare.org. And it has a number of different features that are great, and I would recommend you check it out. One is a quiz that's asking, is palliative care right for you? And then another is a searchable provider directory where you can look for palliative care providers based on your geographic location. So why doesn't every patient with ovarian cancer get palliative care? Let's talk about some barriers to that. So in terms of availability, there are not enough specialty palliative care providers in the country to provide specialty palliative care to everyone who might benefit from it. And there's a lot of talk in the specialty palliative care community now about how to target the available specialty palliative care capacity to patients who will most benefit from it. I personally feel like sometimes the specialty palliative care community jumps too fast to the solution that, well, the oncologist should just do more of it. But I think that that's not practical, because if we're asking an oncology team for increased attention to these critical elements of the care of a woman with ovarian cancer, symptom management, critical conversations, advanced care planning, we would have to increase the capacity of that oncology team in terms of both education and their skill set, and then clinician time. Is we can't just assume that an oncology provider who's probably already seeing as many patients as they can fit into a day and not with hour-long appointments, I think it's not reasonable to expect the oncology team to suddenly add good, high-quality primary palliative care into those same visits. I think the next barrier is poor reimbursement at the system level. I didn't go into this really today, partially due to time and partially because I think that these system-level things are less important than the individual benefits. But in our current healthcare system model, in a fee-for-service way, palliative care services are not well reimbursed, and so it disincentivizes hospital systems, are not incentivized to build these palliative care programs and offer them to patients. And I'm just going to get up on my palliative care soapbox for 1 second and say that I think if palliative care was a drug that a drug company made and stood to make a fortune off of, and it had demonstrated benefits like palliative care has demonstrated, we would be giving it to every single patient with advanced cancer. But so I do think that the finances of it are relevant to some of the limitations in incorporation of palliative care more broadly and implementation of that. And the next barrier is lack of provider education. So I think our training, and I speak as a GYN oncologist, leaves us inadequately prepared for the role of primary palliative care provider. And this is a survey now that's over 10 years old. But over 300 GYN oncologists, only 45% said that their training had helped them at all relate to terminally ill patients and families. In that same study, almost 80% of respondents felt that more training in end-of-life care would be helpful to them in caring for their patients. Another survey of just over 100 GYN oncology fellows who are still training, they rated the quality and quantity of their palliative care training as far lower than other common oncologic topics and procedural issues. And in that survey, almost 90% of the fellows said that they felt that palliative care was important or integral to their training, but only 10% reported getting the training that they felt like they needed in that respect. And then this is a survey of GYN oncology fellowship directors, so in charge of curriculum for training GYN oncologists. Only 14% had any written curriculum for their fellows around palliative care. But encouragingly, almost half of them said that they had at least an elective, if not required, palliative care rotation available as part of the training of their GYN oncology fellows. And then just for a little bit of comic relief, the final barrier that I want to mention is that I think in palliative care we really have a branding problem where we leave people thinking that palliative care is the death squad or the death panel. And this cartoon just shows the Grim Reaper and people saying he's our new palliative care specialist. And so I think we have to do better in terms of branding with palliative care with both the public and providers. So this is the data from the public opinion poll that I mentioned that Center to Advance Palliative Care did. That's the same question that we did as an audience question here. So this data is about 5-6 years old now, but the Center to Advance Palliative Care surveyed 800 adults in the U.S. They oversampled older folks over the age of 65. These people did not themselves necessarily have a cancer or a life-limiting illness. This was just a general public opinion poll. But they found that 70% of people describe themselves as not at all knowledgeable about palliative care, which means that we have a branding problem. We are not effectively educating people about what palliative care can offer. So certainly it seems from our poll like we have a much more educated audience here, which is not surprising. Clearly you all have made efforts to educate yourselves and be involved and utilize the wonderful resources that SHARE has to offer. But I think broadly still people are undereducated about what palliative care can offer. I think palliative care also has a branding problem with healthcare providers, with physicians who have been shown to have a lack of knowledge of palliative care services and their benefits. Physicians, including oncologists, often equate palliative care with end-of-life care, and so then it's not surprising that that misconception would be passed on to patients. And in some ways, I think that physicians or the branding issue with providers is actually a tougher nut to crack, because whereas patients often just have a lack of knowledge, providers often have existing misconceptions that we would have to sort of reverse. And other research has shown that patients, even those who have demonstrated unmet palliative care needs like poorly controlled symptoms, are unlikely to request a palliative care referral. At the same time, for the most part, patients really are generally very open to a palliative care referral when it is recommended by their oncologist. So I think that means we really need providers, oncologists, to be educated about palliative care and take the initiative to bring that up with their patients. Some institutions, I think that some of these misconceptions, particularly with oncologists, run so deep that some institutions have taken to renaming their palliative care services or divisions, often substituting the term supportive care, to try to circumvent some of these negative connotations and misconceptions. They did that at MD Anderson, I know, and then looked at some pre-post data, and they found that their referral rates actually went up after they changed the name of their clinic from palliative care to supportive care, without changing at all the services that they offered. So I think the issue of how palliative care is understood, or often misunderstood, is so important that in 2014, the Institute of Medicine, in their report on dying in America, concluded that one of the greatest remaining challenges is the need for better understanding of the role of palliative care among both the public and professionals across the continuum of care, so that hospice and palliative care can achieve their full potential for patients and their families. So this is our last audience poll.
Okay. So I'm going to launch this poll. After listening to this webinar, how likely are you to consider palliative care for yourself or for your friend or family if you're a caregiver? And your answer choices are very likely, somewhat likely, not too, and the last choice is not too likely or not likely at all. So we have got about 2/3 of our folks have answered already. But let's wait a few more seconds to see if anybody else wants to answer this poll. about how likely you are to consider palliative care for yourself or for your friend or family. Okay, so I'm going to close the poll and share the answers. And it looks like everybody is very likely. That's all of your presentation so far. All right,
I'm promising. Oh, did you put me back in charge of the slides here? Okay, so this is again a question that was asked, the exact same question in the national public opinion poll that I've mentioned that the Center for Advanced Palliative Care did. And so this was after they had come up with this definition that I read you, in this long definition that includes the phrase an extra layer of support. And then after orienting people to that definition, asked how likely, if at all, would you be to consider palliative care for a loved one if they had a serious illness. And you can see that over 60% said very likely, and over 90% said either very likely or somewhat likely. And so this is the same population that had started out that poll, 70% being not at all knowledgeable about palliative care. And so when those same people who started out not at all knowledgeable about palliative care were informed about what it is, using that definition that we talked about, they had an overwhelmingly positive reaction. So the public have tended historically to be under-informed about palliative care, but when informed, generally tend to have a positive view of being open to it. So let's talk a little bit about next steps in the quest to improve palliative care integration for women with ovarian cancer. I think, like any other area of healthcare, progress will require additional education, research, and policy progress. I think we need education for both patients and providers about what palliative care is and is not, and really about trying to foster culture change around the normalization of integration of palliative care as a part of routine cancer care. And that's why I'm so grateful for the opportunity to talk to you all about that this evening. I think we need more research that looks at symptom management, and particularly separately in different illness populations. So I think the symptom profile of women with ovarian cancer looks different than the symptom profile of men with colon cancer, and that you really have to study those populations individually. I think we need more research about how to best utilize palliative care specialists, and how to best elucidate patient and family values and make sure that we are matching among our treatment options, matching treatment plans to those goals and values. And I think we need policy that really recognizes and values the contribution that palliative care makes to the care of people with cancer, including ovarian cancer, and incentivizes the growth of palliative care service availability. And I feel currently there are a lot of ways in which our healthcare system disincentivizes those things. I know that this audience is so rich with passion for the lives of women with ovarian cancer and saving the lives of women with ovarian cancer. And I would argue that saving lives is not just about helping women with ovarian cancer live longer, but also helping them live better. And I think that improving palliative care integration is one important path to doing that. And it can be as simple as working to normalize palliative care as a routine part of cancer care among your friends and families and the communities in which you live and work. So to review our objectives, because I do want to leave some time for questions, hopefully you now feel able to define palliative care and differentiate it from hospice care. Feel familiar with some of the evidence-based benefits of palliative care, which include improved quality of life, improved patient and family satisfaction with care, and other clinical benefits, all without any decrease in survival. Hopefully you feel able to differentiate between primary palliative care delivered by your primary care physician or your oncology team, and specialty palliative care, which usually involves being referred separately to a dedicated palliative care team. And then for your homework, I want to really encourage you to at least familiarize yourself with the palliative care resources available near you. And I think probably the two best ways to do that are either by asking your oncologist or looking on getpalliativecare.org. And so take-home points, what is palliative care? It is an extra layer of support for women with ovarian cancer and their families that advocates for optimization of quality of life. Why do we need palliative care? Because it improves clinical outcomes without adversely affecting survival. How can you get palliative care? You can ask your oncologist. You can go to getpalliativecare.org. And in terms of the when of palliative care, I think that the answer to that question is a little bit different when you're talking as a systems person thinking about national use of resources versus as an individual. I would say for any individual woman with ovarian cancer, when palliative care, I would say why not now? If those services are available to you where you are, take advantage of them. I think the question of how do we best use the limited palliative care specialists nationally is a whole separate question. But in the meantime, if you have access to that, I would say take advantage of it. And this is just a picture of our university campus with the Colorado Mountains in the background. And
okay.
Yeah, that's it. So I think that leaves us 15 minutes or so if folks have questions.
Right. Yeah, so we did have a few questions that were submitted. And you can also still submit you can still submit questions into the question pane on the screen, and we'll still take those. Now let's start with the Q&A. So please keep in mind that not all questions submitted will be asked due to the clinical nature of some questions. If you submitted a question and you do not hear the question, please feel free to call the SHARE helpline, and a trained survivor will be able to help. So our first question that was submitted is, when should a palliative care doctor become part of your medical team, especially for recurrent ovarian patients?
Yeah. So clearly I'm biased in favor of the benefits of palliative care, but I would say there's not really a bad time. So if I try to think devil's advocate to myself, what would be the downsides to going to see a palliative care doctor from the moment that your ovarian cancer recurs for the first time? I think the only downsides are if you have to maybe travel really far to get to a palliative care specialist in a way that presents some sort of time burden or financial burden to you or your family. You'd have to weigh that. Or people sometimes talk about fragmentation of care, and do you worry about having too many cooks in your kitchen? You already have an oncologist, you have a palliative care doctor. And so I do think that the relationship between the palliative care doctor and the oncologist is important. And you want, obviously, those folks to talk to each other, which you should expect of them to be able to do. And so I would say, to me, the sooner the better, because if you go, I mean, even for upfront diagnosis of ovarian cancer, symptoms that come with that, the emotional burden that comes with that diagnosis for patient and family, I actually think that probably the time of diagnosis is among the higher palliative care need time between symptoms of the cancer itself, symptoms once you get started on treatment, and kind of the emotional burden of that adjustment for the patient and her family and what it means for the future is a high palliative care need time. And so if you go and see a palliative care doctor and they spend an hour with you and they talk about your symptoms and they sort of make sure you have decent understanding of your illness and talk to you about how you and your family are coping and give you a chance to, talk about some advanced care planning in a non-crisis situation, there's value to that. And maybe you get through that visit and then you know that team, and maybe you don't go once a month. Maybe you say, I'll call you if my symptoms get worse, or if things change and I have a new branch point in care where I'm trying to decide between options and I want somebody to sort of help make sure that I'm making the right decision for me and my goals and values. Just because you go once doesn't mean you have to go see them every month. But so I would sort of say the sooner the better with any diagnosis of an advanced stage cancer, ovarian cancer, or a recurrent ovarian cancer, if the option is available to you to see a palliative care team. Because the other thing is feel them out. See if it feels like it'll be helpful. The worst that happens, you go and you have a visit, and you don't feel like you have a lot of needs at that time, then you don't go back for a while. But you know that they're there, and you have a better sense of what's available to you.
Okay. And then we had a few questions come in about how to connect to palliative care resources. Yeah, how can you find these resources? Is a patient navigator or oncology social worker a good way to connect, or how do you go about it?
I think that's a great question. So I think if you're talking about finding actual palliative care doctors, you can go to getpalliativecare.org and search by your location. I would personally say it's a good idea to broadly ask your oncologist or your oncology social worker, your patient navigator, your oncology nurse, whoever's kind of your portal to the oncology team, say, I'm just wondering if you can orient me a little bit to and you can use the phrase supportive care services available here at this hospital or here at this practice or here at this university. And you can even say, I was listening to a webinar about palliative care integration in ovarian cancer alongside chemo and surgery and such, and I'm just wondering if you can tell me a little bit about what's available here.
Okay, and we just had a question come in. Do health insurance companies, including Medicare, usually cover palliative care?
Great question. Yes is the short answer. I think it's like a doctor's visit, like any other doctor's visit, so you may have and I obviously can't speak to all insurances. I know that when patients get referred to my palliative care clinic, the intake process involves some sort of insurance screening the same way it does when they get referred to my oncology clinic. And so folks may have a copay for an outpatient visit. Certainly inpatient consult services are covered, the same way a cardiology consult service, a cardiology consult would be covered if you were in the hospital. And then this is a whole sort of other issue, but really the reason that you can't get hospice care, which is the most service-intensive version of palliative care that you can get at home, the reason that you can't get hospice care alongside, say, chemo, like while you're getting chemo, really goes back to the way that Medicare is funded. And so Medicare, which is the model generally for all other insurances' hospice benefits, once you invoke the Medicare hospice benefit, then it's sort of mutually exclusive from Medicare-funded cancer treatments, which is kind of a bummer because I think that the same way concurrent chemo, let's say, in palliative care has benefits, I expect that concurrent hospice care at home, just meaning extra visits from nurses and specialists in symptom management, and a team that knows your family and meets you at home would also have value. And Medicare is actually now doing a demonstration project that's going to be a couple years long where they're inviting hospice agencies to offer the same services that they've historically offered as hospice services to patients who are still getting, let's say, chemotherapy, radiation therapy, and they're going to look at the clinical outcomes of those patients versus the patients who can only access hospice once they're no longer getting chemo, radiation, et cetera. And so I personally am looking forward to the data from that, because my hope would be that we don't have that line in the sand drawn in the future that keeps people from these more intensive palliative care services while they're getting chemo.
Okay. We had two questions asked about what is included in palliative care. Basically, one person just asked what is included in palliative care for ovarian patients, and somebody else was wondering specifically if help advice on clinical trials is something that palliative care providers.
Sorry, I just say that last part. Sarah, can you repeat that question?
Sure, yeah. So folks are wondering if you could talk about what is included in palliative care for ovarian patients, and one person also specifically asked if they can help with advice for clinical trials, on like connecting with clinical trials.
Can palliative care help with that?
Yeah.
Yeah. Okay, so in terms of what is included in palliative care, I think it depends on what the patient's needs are. I think the scope of what palliative care can offer is sort of summarized on that slide about domains of palliative. Can I flip back? Are people still seeing these slides?
Yes.
Okay, so I'd say the full scope of what palliative care can offer is sort of in these domains here, and the question of what services would be offered as part of a specialty palliative care, say consultation or co-management for an individual woman with ovarian cancer would really depend where her needs are. So I see some ovarian cancer patients in my palliative care clinic who I don't do oncology and palliative care for the same patients, but I see some of my partner's patients. And for one woman's first visit, we might spend 90% of our time on symptom management because she really has uncontrolled pain on that day when I meet her. And another woman may not have very much in the way of symptoms at all, but her oncologist has offered her these sort of 3 different options of path forward, and she's really just trying to figure out what is the best fit for her. And in that scenario, I would take the oncology information in terms of what each of those paths include, chance of benefit, burden, side effects from the oncologist, but then use my palliative care skills just to facilitate a goal-based conversation to try to help match between those options and that patient's goals and values. And maybe that's the way we spend our whole visit. So from patient to patient and even from visit to visit, what we actually spend our time on really kind of depends where the needs are. And then you might have a patient who's really just struggling with coping or how her cancer diagnosis has impacted her family, and I may do some of that counseling, and then can also serve as a portal for coordination of care. I may refer that woman to our cancer center psychologist or a caregiver support group or whatever else might help in supporting that patient and family. And so in terms of the clinical trial piece, I think your oncology team is your best portal for the question of what clinical trials are available and what standard therapy off protocol treatment options are available. But then I think the role of a palliative care provider in that setting might be to help the patient think through those options and talk through those options. And again, I have the luxury of an hour to spend that the oncologist doesn't. And so, because I would see a palliative care patient with a cancer I don't treat, I always take the oncologic information from the oncologist and then help the patient work through it in making decisions between options. So I don't know if that answers the clinical trial question or not.
Yeah, I think that's helpful. Okay, and you had mentioned in your presentation about the branding problem of palliative care. And we had one question submitted. This was submitted in advance of the presentation. If I ask for palliative care, am I signaling to my doctors that I no longer want to actively treat my cancer? And yeah, so what are your thoughts about that concern?
So I would say certainly it shouldn't be. So to an oncologist who has an accurate understanding of palliative care and what it can offer, absolutely you would not be. I think the problem is that not all oncologists have that understanding, and it's not because they don't want to optimize the quality of life for their patients or they don't want their patient to have access to something that might help them. I think it's purely a relic of how we have trained oncologists and how we have failed to spread the word accurately about what palliative care is and what it can offer. And so you might want to kind of preemptively, because I do this sometimes when I refer, so I refer my own, say, ovarian cancer patients. So I have a patient, I'm treating her ovarian cancer, and I have 15 minutes in the office. I can't provide good palliative care to that patient. She has a high symptom burden or some critical conversation needs. So I'll refer my ovarian cancer patients to see a palliative care specialist. And when I mention it, in case the patient has misconceptions about palliative care and hospice, I'll usually just come out and say, even if they don't ask, you know, it sounds like you're having quite a bit of pain, or it sounds like we've got kind of a decision in front of us and a couple different options, and I think it would really help for you to go and have a separate visit with Dr. whoever, you know, over at the palliative care clinic, because they really are specialists in symptom management and helping people make decisions at branch point in their care. I think that would really add value to your care. You know, some people, when they hear that, think that I'm talking about hospice or end-of-life care, or think that I mean that we don't have ways to continue to try to extend their life or treat their cancer. And I just want to mention that because that's not what I'm talking about. I'm talking, you know, blah, blah, blah. I'm talking about an extra layer of support. I'm talking about value added in a way that doesn't at all limit our options for treating your cancer. I think just helps us make better decisions about how to do that are more individualized to you and your family. And so I do that as an oncologist, and I think you can do that as a patient just to clear the air and make sure there's no misconceptions. And you can say, you know, I was listening to this webinar, and it was talking about palliative care alongside cancer care, and I'm wondering if that's something that's available here. And I'm hoping that, you know, could be a supplement to the symptom management we talked about here, whatever you want to say. And I just want to be clear to make sure there's no misunderstanding that I'm not talking about hospice care. I'm not talking about closing doors around options for treating my cancer. I'm talking about adding. I'm talking about an and, not an or. So I would probably just say, call out the elephant in the room just to make sure there's no misunderstanding.
Oh, yeah. Yeah. And like you said, in the research you had mentioned that palliative care in the research shows that it lengthens life. So it's not like people are generally, doctors are being signaled generally, you know, to end cares. Yes.
Yeah, I mean, hopefully not, you know, and I don't want to overstate the rigor of the research or the idea, you know, we don't have a randomized trial in ovarian cancer patients that shows us those outcomes. I think it is still conservatively safe to say, at the very least, we have no studies that tell us that this shortens people's time, and it may even prolong prolong people's time. And I think it's a funny role reversal to maybe think about being the one who's educating your oncologist rather than the other way around. But, you know, I would like to think as an oncologist, like, give us the benefit of the doubt that we, you know, want to structure your care in a way that optimizes your quality of life and meets your needs in a way that is personalized. I mean, I think we're all about personalized medicine now, and when we talk about that in oncology, we are often talking about genetically personalized medicine, and I think that it's just as relevant to personalized treatment plans to patients' goals and values and what's important to them and their family. And I would like to think that as oncologists that we want that for all of our patients. And so if you as a patient, you know, have thoughts about an element of care that you might like to sort of try out or access that you think might add value, I'd say go ahead and assume that your oncologist, once you make sure that they have an accurate understanding, would be all in favor.
Okay. I think that we'll have to wrap up there. Now, the end of the hour we have with you. And I'd like to thank you, Dr. Carolyn Lefkowits, for an informative program, and thanks to all of you for participating and attending and for submitting your questions. Please take a moment to fill out the survey at the end of this webinar. It might take a minute for the survey to load after you close the webinar, but please try to fill that out. That really helps us improve our programs. All right, thank you.
Okay, thank you.